The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shannon McKernan, and today I'm interviewing Dr. Timothy Gilligan from the Cleveland Clinic, lead author on Patient-Clinician Communication, American Society of Clinical Oncology Consensus Guideline. Thank you for being here, Dr. Gilligan.
My pleasure. Thanks for having me.
First, can you give us a general overview of what this guideline covers?
Yeah, so the purpose for this guideline was to give support to clinicians working with cancer patients in terms of what core skills they should aspire to, or what core skills we expect from healthcare professionals taking care of cancer patients, with some focus on the particular challenges that a cancer diagnosis presents. So our hope was that this would help design or help people design training programs to teach communication skills and help people get a sense of what to work on. And I mean, I think for each of us, however good we are at a given moment, we aspire to be better as part of what being a professional is. And so this, in a sense, is kind of defining what we think of as excellence in communication, or what we aspire to.
And what are the key recommendations of this guideline?
So it's broken down in a couple of different ways. So the overall framework that we're really recommending is something referred to as relationship-centered communication, in the sense of trying to communicate in a way that builds a stronger, more trusting relationship with the patient, in which the patient's autonomy is respected, the patient is empowered. So that was kind of a theme running through a lot of this, that what we would like is to have a stronger relationship, or as strong a relationship as we can, with patients and their family members, and a mutually respectful and trusting one. So the first part of the guideline really talks about core communication skills that apply to almost any conversation. And there were 5 key points there. One is the importance of preparation. So rather than kind of going into an encounter and winging it, the importance of reviewing the patient's medical information in advance and anticipating what's going to come up in that encounter and what the needs are going to be. Second piece is taking time to explore the patient's understanding. Oftentimes, clinicians really focus on delivering information to the patient. And if we don't know what the patient already knows, then we don't really know who we're talking to, and we don't really know where to begin the conversation, or how to frame it, or how simple or complicated to make it. So thinking about really exploring the patient's understanding at the beginning and collaborating with them to set an agenda. So in our time together today, what is it that you want to cover? What's most important to you? That kind of a thing. We emphasize also as a core behavior, thinking about behaviors that actively foster trust and confidence in the clinician and that support collaboration. So we're trying to flatten the hierarchy a little bit, but also to pay attention to that issue. I think sometimes we sort of assume that because we're a doctor, or because we're a nurse practitioner, because we have a white coat on, because we have initials after our name, that therefore we will be trusted. And we forget that we actually need to earn that trust. So we can think about what are the sorts of behaviors that foster trust and support it. We want to think about what the patient is most interested in when we think about giving them information. What we're most interested in as clinicians, what we think is most interesting or most important, may not be the same thing as what the patient is most concerned about. So taking some time to find out what the patient wants to know, what the patient is most worried about, so we make sure that we address that as well as the issues that we think are particularly important. And then when we do give information, checking to see whether or not it was understood. There's literature showing that patients accurately remember about 25% of what they're told at medical visits. And we thought we could aim for a number higher than 25%. And one way we can find out whether the patients are understanding is to check with them. And that's often not done in medical encounters. And then the last core skill really is empathy, that being sick is an emotional experience. It's scary. People may get angry. They may get sad. They may grieve. They may feel disempowered. They may feel hopeless. And if we just respond cognitively or with information, then we're kind of missing the patient's emotional experience. So learning to respond empathically showing the patient that we are trying to understand what they're going through. So for me as an oncologist, that means trying to understand what would it be like to have a doctor tell me I have cancer, or if I already knew I had cancer, what would it be like to hear that it had come back or it had spread or that the treatment was or wasn't working, so that then when I talk to the patient, I can speak in a way that's informed by that understanding of, what it would be like to be in that situation. Or maybe it's one of my kids, or maybe it's one of my parents or someone I love. It also applies to family members. So those were kind of core skills we tried to define that people can bring to any conversation. And then we broke it down into specific challenges that oncologists face. So discussing goals of care and prognosis, trying to find out what the patient thinks is most important and what their goals are, and to be clear about what's achievable, so that when we come up with a plan, the plan is in relationship not just to medical science, but also to the individuality of the patient and what they want, what matters to them, allowing them then to participate in the decision-making and do shared decision-making rather than have us just tell them what we think the best thing to do is. We have a section on discussing treatment options in clinical trials that talks not only about goals of care, but also about just the importance of making sure patients know all of their options. One of the ways I think of that is that, there are a lot of areas in medicine that I know that if my patient were to see 3 other doctors who do the same thing as me, they might get 2 different recommendations. And so for me to really do a good job communicating, I should make sure the patient knows that I can tell them what I recommend, but I should also tell them what other people might recommend and what the pros and cons of each of the options are. And again, let them participate to the extent that they want to. Other topics we address are how to discuss end-of-life care. I think one of the things that may be unexpected there is that there are a number of organized frameworks that have been published that can help guide end-of-life conversations. And we really encourage people to use those to have a structured conversation, not just a improvised or winging a conversation, but to have a plan for how to make sure that the conversation's had in a skillful way. We talk about how to use communication to facilitate family involvement in care. I think many of us in oncology find that cancer patients can get better care when their family is supporting and understands what's going on, and I often feel like family members sometimes serve as medical assistants at home because they're really helping to take care of the person. So thinking about how we can encourage that involvement and make the family feel welcome, make them feel like we're glad that they came in with the patient, and that we keep them informed and answer their questions as well. There are a couple of sort of more specific areas we talk about when there are barriers to communication. If there's not a common language and you're working through an interpreter, that's very challenging to have a delicate conversation about cancer, end-of-life care, stuff like that. So we provide some guidance on that, although I think that's a particularly tough area. And then there are patients with low health literacy or low health numeracy who have trouble understanding, and just some guidelines about how to be responsive to that and how to assess for that. If a patient's not able to understand information we want to give them, spending a lot of time trying to give them that information can be time that's not well spent. There may be better ways to address it. We may need to think about what's achievable rather than what's perfect, and then use skills that can help us get as far as we can with a given person, in their particular setting with their background, etc. We have some brief section on discussing cost of care. We didn't say a lot about that because there's not a lot of evidence on what patients want. It's clear that cost of care is causing a lot of bankruptcy and economic hardship for cancer patients, but there's conflict in the literature about whether patients really want their cancer doctors talking to them about cost of care as opposed to really focusing on the cancer and the treatment. But we did recommend that at least that we give patients an opportunity to talk about it, and we explore whether or not they want to address it. But we didn't make a lot of recommendations in that regard because we just don't know enough yet. We need more research in that regard of how we can be most helpful to patients struggling with cost issues. We talk about underserved populations because of the vast disparities in cancer care and cancer outcomes for African Americans and other underrepresented groups, and also just specifically working with patients of different sexual orientation and gender identity. And then lastly, the last section is about how do we train clinicians to communicate better. And there's good evidence there that we know what works, and we know a certain amount of what doesn't work. And the bottom line there is that the only thing that has been shown to work is practice. So cognitive-based teaching or didactics or lectures have no measurable impact on future performance. But if we set up opportunities for people to practice communication skills and to get feedback and to work on specific goals, there are numerous studies showing that we can improve outcomes. We can improve measured skills, and we can also improve patient experience. But it's important to have high-quality training with people who know what they're doing, who know how to do this kind of work, who know how to run role-play scenarios, for example, or look at video encounters, and give skilled feedback in a way that's actually helpful to the learner. And that's really what's covered. It's a lot in the guideline, and it's the first time that ASCO has put out a guideline on the subject. And we're hopeful that it will be read and people will think about this. And I think the biggest opportunity is to impact training opportunities, both CME and fellowship training, so that we start to take seriously how difficult it is, some of the conversations we have with cancer patients, and how much practice it takes to really get very good at them. But there's a lot of evidence that communication affects quality of care and outcomes and patient experience. So I think there's a big benefit to our patients if we do get better at this. And we also think there's a benefit to us that our work lives become more satisfying when we have better conversations, we have better relationships. So we think both patients and healthcare professionals benefit alike.
And can you tell us about the consensus process used to develop these recommendations and why that approach was used for this guideline?
Yeah, we use the consensus process when we don't have a lot of randomized controlled trials telling us definitively what the right thing to do is. There is a fair amount of literature and research in the communication area in healthcare and in oncology in particular. So this was based as much as possible on studies that have been published. But it's easier to study or to measure whether a patient lives longer after they receive drug X compared to drug Y than to measure the benefit of having a specific conversation this way as opposed to that way. So our approach here really was to put together an expert panel to come up with initial guidelines and then to share it with a larger consensus panel of experts around the country and the world, and really get feedback to make sure that we were in agreement, that we weren't going too far, and that there was a sense that what we were recommending was the current state of the art and what experts think is best based on the literature that has been done. So, but again, the reason to use the consensus process really was because we don't have the kind of evidence that would allow us to be more definitive.
And finally, how will these guideline recommendations affect patients?
Well, I think, we get a lot of feedback from patients, both about what we do well and what we could do better. I think oncology attracts a relatively humanistic group of healthcare professionals because we've chosen to work with patients who are often dealing with terminal illnesses, and it takes a particular kind of person to want to do that. But there are areas where we come up short. I think one of the big complaints is that we don't listen enough, that we don't take enough time to really understand the patient's point of view, that we don't give them the information that they want in a way that they can understand it, that we sometimes are not as empathic as they would like. In other words, we don't really seem to get what they're going through. And so my hope with this guideline is that if we can continue to do well what we're already doing well, and maybe get better at spending, of the minutes we have with the patient, maybe spending more of those minutes listening and fewer of those minutes talking, and focusing more of our energy on building a trusting relationship with them. I think that will improve patients' experience, make them feel more connected with us. Because when we, I think in general, I actually think we do a good job, but when we get it wrong or when we don't do a good job, our patients suffer, and none of us want that. And so my hope is that patients will be happier with their care, feel more supported and understood by their caregivers, and that we will ultimately make this journey that they're going through easier for them.
Great. Thank you for your time today, Dr. Gilligan, and thank you for your insights on this important guideline.
My pleasure. Thank you for having me on.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.